Good evening, and thank you for joining us for SFU's Science Virtual Town Hall. The plan is to engage in conversation with three exceptional scientists who are on the leading edge in the race to address issues related to COVID-19. They are leading the path forward in the COVID-19 campaign, and in doing so, bringing back a sense of safety to our community. And we're going to find out whether or not we're actually truly bringing back that safety. Are we going to have a clearer idea of what it is, how we get there, what are some of the challenges that we still face? So my name is Stuart McNish. I host a show from the studio right here called Conversations That Matter. It's an affiliate program of the Morris J. Wass Center for Dialogue at Simon Fraser University. And in the course of that show, I frequently get to interview scientists. And it's something that I always just love to do because I get to dig into their world, into their work, and discover elements of life that are, well, they're beyond my reach and probably beyond the reach of most of us. And so, here we have women and men who dedicate their lives to science, who are invigorated and energized by minute details that 99.9% of us, well, we can't comprehend them, or at least I can't. And I can't, it's hard to even find the will to work our way through that to understand it. And so therefore, we're even more grateful of the work that scientists do, and that they love their work, their research, and they have this incredible ability to understand the world, as I say, in such small detail, see how it works, envision a different outcome and better outcomes. So yes, I am thrilled to be your moderator tonight as we broadcast live from Oh Boy Production Studios here in downtown Vancouver. Just so you know, the agenda for the evening is as follows. In a moment, we will be hearing from the Dean of the Faculty of Science, Dr. Paul Kench. And once he finishes delivering his message, I know that you'll want to know how to donate to the work that's going on, especially in this campaign. And that's money that will go to the faculty in supporting this vital and important research that they're doing, not only for COVID-19, but beyond. Then I'll walk you through the process of how you can actually connect to the donation site. There's a button on the screen just below where I'm speaking right now. And once I'm certain that you know how to operate that button and that you can engage with it, then when I'm certain that you know how to do that, we'll move on into the interview section with each of the scientists who are joining us tonight. Those interviews will be one at a time, first of all. They'll morph into a group discussion, and then we're going to open it up to you for questions. I'd like to suggest that if you sense that you want to ask a question, you can, and feel free to ask early. There is a panel just over here that allows you, and it says up at the top, SFU Science Virtual Town Hall. It will allow you to write in a question. You'll see the prompt there that says, ask the speaker. Simply type in your question. We'll receive it here into the studio, and it'll get put into the queue. And if it's a particular question that you have for one of the scientists while I'm doing the interview with them, please feel free to send in that question. It will come to me, and I'll be able to see it. And if it fits into the flow, well, then we'll ask that of the particular scientist that I'm speaking to. And then we'll have a formal Q&A session at the end where we'll try to get to as many of these questions as possible. So pause with me for a moment to recognize that we are at a benchmark moment in history. As of today, more than 9.6 million cases of COVID-19 have been confirmed globally. Almost 500,000 people have died. 213 countries and territories around the world have now confirmed the virus is present. The world has changed. Our world has changed. COVID-19 has challenged all of us in so many different ways. Everyone has been threatened by the global pandemic, our health, our livelihood, the safety of our social connections and interactions. Our communities have been stilled by the closing of our economy in an effort to slow this pandemic. We all continue to watch, and we watch eagerly because we want to hear those words that we are once again safe. Is it safe? We want to know, are we safe? But the path towards safety continues to be unclear. It is continuing to unfold. So now as we slowly reopen our economy, many of us can't help but ask the question, what is the risk? What is the risk? So before we get to the exciting work of the researchers, I have the honor of actually introducing you to another one of the scientists that is with us here tonight, the Dean of the Science Faculty at Simon Fraser University, Dr. Paul Kench. Paul, the Path Forward campaign, what is it? Why is it important in the global response to COVID-19? Where to from here? And of equal importance, how can viewers support this campaign?
Thank you, Stu, and welcome to everyone that is joining us tonight. SFU Science is delighted to put the spotlight on three of our outstanding faculty members who are part of a global scientific community that has come together to fight COVID-19. The research we are highlighting focuses on the challenges of predicting and modelling the spread of COVID-19 among our community, the development of novel tools to improve our COVID-19 testing and tracing capability, and development of new antiviral therapeutics to combat COVID-19. Dr. Caroline Colleen's research in mathematical pandemic modelling is informing the responses of the BC Centre for Disease Control, the province of BC, and that of Dr. Bonnie Henry, our Provincial Health Officer. Dr. Colleen is also a member of a multidisciplinary science expert panel handpicked by the Chief Science Advisor of Canada to advise on COVID-19 matters. Dr. Peter Unrau and Dr. Rob Britton are both changing the game in COVID-19 testing and therapy. Prime Minister Justin Trudeau continues to speak about the need to increase our country's capacity in testing and contact tracing, two integral components to controlling the resurgence of COVID-19. The ability of our communities to have access to a rapid detection kit that is accurate, inexpensive, and easy to use would bring a sense of safety and means of control. They are also working on furthering antiviral drugs with new technologies and processes that can be used to help discover new frontline therapies against COVID-19 and other emerging viruses. The Path Forward COVID-19 campaign is targeted at raising funds to support their critical work. The multitude of collaborations and information sharing with the BC Centre for Disease Control and other organisations continue to add urgent priorities for our researchers. Doctors Colleen, Unrau and Britton need support so their research can accelerate. Funds raised through this campaign will provide them the ability to hire 2 postdoctoral researchers to assist with their game-changing research during this crucial time. I want to personally thank Drs. Colleen, Unrau and Britton for taking the time to participate this evening, and again, to all of you for joining us.
Thank you, Paul. I know the goal of the Path Forward campaign is to raise $200,000 through community support. For all of you who are tuning in, I once again want to direct your attention to that Donate Now button that's just below the screen. I know you may be hesitant to click on it right at the moment for fear that you might miss out on the discussion with these distinguished panel members. But let me put your mind at ease. You can hit the donate button and continue to watch and listen. By clicking on the Donate Now button, it will launch a separate web page, and you won't leave this page. It'll stay active so that you can continue to hear and look. You know, if you have a single screen, you can reduce those 2 pages. You can make sure that you have your finger on that donate button and still watch and listen. And, if you're on other devices, you're going to have to see how it, materializes on that device. The point being, I don't want you to hesitate from donating for fear that you might miss out on this really exciting discussion. And at the risk of belaboring the Donate Now portion of the show, just in case you don't get a chance to donate now, we'll be in touch with you afterwards so that you can donate then. Let's face it, funding is vitally important in scientific research, and we're all are constantly being asked to donate money, which is particularly challenging for so many of us at the moment because there's uncertainty about the economy and our finances. But thank you so much for joining us and expressing a willingness to support the science of combating COVID-19, especially in these trying times, knowing just that there is this uncertainty about finances. So thank you very much for your willingness to support, listen, and consider a contribution. Now to the exciting part of the evening. It's almost like I want to have a little drum roll here because this is the part that I like the most. We get to dig into the science. As you'll see on your screen, I'm joined by Doctors Carolyn Colane, Dr. Rob Britton, and Dr. Peter Unruh. Carolyn, you specialize in researching in the interface of mathematics and the epidemiology and evolution of pathogens. You hold the Canada 150 chair in mathematics for evolution, infection, and public health. Like, holy smokes. You're currently focused on rapid response modeling for the COVID-19 pandemic. And as I start to think about this, I go, how on earth do you do that? Like, it is so complex. And so I don't even know how you begin the work of saying, this is the information that I need to be able to create a model. Maybe you can explain to people, how do we go about creating those models? What are the inputs of information that you need to be able to send along information that can make a difference for people who have to make decisions?
Sure. Great question. I think, one of the answers is we don't do all of the things at the same time in the same model. So we think, what questions do we want to answer? And we think about building a model that can answer those questions. So we would start with a representation of us, people, and their behavior, and a representation of the virus and how well it can move through a population of us with our behavior. And we compare what the model thinks will happen and what actually happens in the world. So we compare cases in the model and cases in the world, and we fit the model to make sure it's getting the right answers. And then we can think about, okay, what would happen if we changed our behavior? Mm-hmm. How bad would it look? And we answer questions like, how much leeway do we have to reopen before cases start to grow? Given this kind of careful fit, we take into account different streams of data, from Google mobility data to individual data around symptom onset and time of reporting to reported cases. And we put those all together to build a picture of how the virus is spreading in our population. And we use that as a platform to start answering some of the questions that we have.
And so that model has to be specific to British Columbia in your case, does it not?
So some aspects are specific to British Columbia, some of the estimates that we use, but we can also retune the model and fit it to other locations. And we've done that to try to compare, how well the virus spread in those places before measures were introduced, how strong the measures were, how well did they work, and how much leeway did different places have to reopen at about the time of, sort of mid-May when we started reopening.
Well, and I find it interesting you say different places, because the model for, let's say, Osoyoos would be different than that for Nanaimo or Victoria or Vancouver, wouldn't it? So or are we not able to narrow it down that definitively yet?
So in BC, we can narrow it down a little bit by health region. But you might need a different kind of model if you want to look at a place that hasn't had cases. You don't fit the cases to a model because you haven't had them, or you haven't had very many of them. So to think about that, what we look at is making our models for places that do have cases, and then seeing what happens when people start to move around as we reopen. What kind of hazard or risk are we looking at, and when would we start to see cases in new places? And one of the things that happened this week, which was really unfortunate, was we predicted last week that this week we might start to see cases on Vancouver Island, and indeed there was one reported yesterday. So different combinations of modeling approaches will help us with different questions.
So what was it that made you recognize that there was a challenge there on Vancouver Island? What kind of information gave you that insight to be able to make that unfortunately accurate prediction?
Yeah, so two things. One is it looks like cases in the Fraser Health and Vancouver Coastal Health region are not declining the way we thought. They might even be a slow increase, and Dr. Henry presented that in her slides the other day, some of our figures, and increased ferry traffic. So you put those two things together, you just have more risk of imported cases, and eventually that sadly might cause transmission on Vancouver Island and more cases there.
So the whole idea of using mathematical modeling was to be able to flatten the curve. And for a lot of people, we've gotten used to that term. I checked it out. It was first introduced by a University of Michigan researcher, Dr. Howard Markle, who was trying to figure out how to stop the spread of influenza. And so and he didn't have the same kind of tools that we have today. So this is going back 15, 16 years ago when he was doing this. But to flatten the curve, like he was just saying, okay, I just want to slow the spread of the pandemic. But when you hear the term flatten the curve, what does it mean to you now? And how are we able to ensure that we can work with the information that we have to come up with effective strategies that will do exactly that?
I think it's a good question. I would say 15 years ago, we had the modeling tools that we have today. These are not kind of brand new models that are only possible with, neural networks from 2012 or something. So I guess the other comment I would make is that in BC, at least, we didn't flatten the curve. We crushed that curve. That curve didn't continue to grow exponentially, but at a slow rate, and then saturate, and then reduce due to immunity or other factors. That curve didn't happen. And that leaves us now at a very special time because we don't have immunity. We haven't had a curve that came and receded in a natural way. And now we wait, and maybe in the fall there's another curve. That's not what we did. We fought a forest fire back, and it's still blazing over the hill. And now if we turn the hoses off and we have another dry forest here, we're at the same position epidemiologically that we were at in March.
Right.
But we have more knowledge, probably more testing capacity and more healthcare capacity. So we may be able to respond even better. But we didn't really flatten the curve in the end here. We stopped it in its tracks. And now it's there waiting for us.
Well, and we don't have herd immunity or community immunity. And so this ability to create separation, to work with information becomes vitally important in how we move forward, is it not?
Absolutely. And I think that's where we really need to go next. So we have an understanding that broad physical distancing works. It's worked maybe differently in different places, but it's pretty much worked. Now we're at this juncture where we think we're done with doing that. We're not staying away from each other. We want to reopen. But we know there's still a pandemic. As you said, over 9 million cases worldwide, nearly 500,000 deaths. We will not be able to isolate ourselves, and we probably have some level of community transmission ongoing here. So we're at this juncture where now we need a high-resolution understanding of transmission and understanding of how to reduce transmission. And that's where we want to go next with the modeling.
Okay. Now, I know that it's not directly related to the work that you're doing right now, but what role does genetics play in you helping to be able to understand, what next steps might be?
Yeah, absolutely. And that is something that we are getting into. We focused so much on the emergency response mode of getting forecasting, modeling, and estimates set up. But now I think that's a huge part of the next stage. And I'll talk about genetics from the point of view of the virus. So we're not thinking about you and your genetics or me and my genetics. We're thinking about what's the genetic information in the virus that might infect, hopefully not you or me or anyone in BC or elsewhere, but how much can we learn from sequencing the virus? And it's really interesting because that can help shed some light on where a virus has come from by comparing the sequence to other parts of the world and their sequences. And it can shed some light on local transmission. So if you see lots of little, different viruses, that might tell you a different story than if you see one big cluster of very, very similar viruses. So it can help us get a sense of how transmission is happening. And if we understand that, we hopefully can take steps to reduce that transmission very rapidly.
So the work that you're doing, you're not doing this just at SFU. You're doing work that is vitally important with the Center for Disease Control and the provincial government, the Chief Medical Health Officer. How often are you reporting or sending out information that they're able to utilize?
That's a good question. They use our reports, I think, routinely. We have a Slack workspace that is active multiple times a day and several weekly meetings all together with our team, which is centered at the BC CDC and includes people from UBC and SFU and the Department of Fisheries and Oceans and also the CDC. So we do quite a bit of work through that. And then I also have a team at SFU that's building out some of these research areas somewhat in parallel to that group.
So where we're at right now, people think we're coming out of this. You even talked to the fact that we crushed it. We didn't just flatten the curve. We crushed it. It starts to give people a sense that, okay, well, maybe it's gone and we're going to be okay. Let's step back out there. What's your biggest concern about that? Knowing what you know and how you're able to take a look at this model and say, okay, hang on a second.
Yeah, I so wish that was true. And I think, the comparison to New Zealand is really interesting because they really are an island or a set of islands, and we aren't. But also one of the things we saw recently is that if you look at the cases in the Fraser Health and Vancouver Coastal Health regions, they have not been crushed altogether.
Right.
There are still daily cases in the 8 to 10 to 9 to 11 range, and it looks like we're seeing evidence of growth already. One of the things we did in the team at SFU, in the stats and math departments, is we estimated how long it would take. Suppose there's a change in transmission. Knowing what we know from the modeling, how long is it going to take before we notice? We opened schools June 1st. 1 or 2 days a week, the kids went to school. There were very few people in the schools, at least in my kids' schools. When would we notice a change? And it's actually really long. It's 3 to 6 weeks before we would see that change in reported case counts. And it's, we reopened around mid-May, and it's 4 weeks later, and we're starting to see evidence of some increase. And I was very pleased to see those modeling pictures in Dr. Henry's slides the other day. And she expressed some cautionary notes. But on the other hand, we're reopening. We can't stay away from each other forever. The government has to make a decision around what to do, what's most important. So I think we're at a really crucial time, and I wish I could say we crushed it out of existence, but of course we didn't. And it's still there, and we know that we didn't achieve immunity. There's no vaccine, there's no therapy. If we go back to hanging out and having parties and being in bars and being in close contact with others, being in church services, all of these places where outbreaks have been seen, we can expect to see rises in cases. And I wish that were not what I was seeing in the modeling, but it is.
So your modeling says there's a second coming here, or do you think that it's all part of the same wave?
We have lost the wave language. People will use the phrase second wave, and I think, epidemiologically, in some sense, it's still the one big wave because it hasn't receded due to immunity or due to kind of naturally falling off in that flatten the curve way.
Yeah.
And I think we may see a resurgence as we reestablish contact patterns. And I hope that we can find that balance, but keeping on a knife edge is hard. That's why it's a knife edge. It's a thin wedge or thin edge to sit on.
Well, and it comes down to millions of individual decisions about how people choose to respond, doesn't it?
It comes down to that. I should say, though, that one of the reasons BC did really well, we all did our part, and I think it's very important, and I would never seek to undermine that message, but I also wouldn't want to undersell or undervalue the incredibly strong public health responses that we had in preventing outbreaks in hospitals by not treating people in long-term care there if they could be so treated rather than bringing into hospital. Removing bridges between long-term care facilities, some of the really proactive measures that were taken. We have very strong contact tracing in BC, which Dr. Henry also mentioned in her presentation. So those things are also really important as well. It's not all just down to whether I work at home on my laptop, of course, because there are lots of public health measures that were taken.
So there's still a lot of work to be done from a societal, government, individual perspective, but there's a lot of work that still needs to be done from a scientific perspective as well. And, one of the objectives of tonight is to raise money to help you do your work in a variety of different ways, not just on this campaign, but moving forward in, the suite of studies and research that's underway to address COVID-19, with the hiring of funding to hire a couple of postdoctoral students. How would that help you do your work?
So I think it is incredibly important that we build capacity right now. Right now is this critical time. We don't have a vaccine. We don't have an effective treatment. We don't have herd immunity, and we need to understand what to do. And I think no one really knows what to do. And it's amazing to me that we've had 9 million cases worldwide, and we don't know what droplet size and whether surfaces or whether masks or whether restaurants or whether bars. And so many settings have been closed that we don't understand what kind of transmission may happen in those settings. So I think now is the time to start building those higher resolution pictures. Right. And one of the things we know and love in our team is really linking the genomics with the epidemiology and bringing those two pieces together to build that high resolution picture. So I think it's complex and it's detailed and it takes that capacity. And we think we need capacity building in understanding epidemics because this thing, unfortunately, is going to be here for a while. Yeah, it is going to be here for a while. And the more information that you're armed with, the better you can work to, come up with models that will help us to make more informed decisions about whether we are or not safe. And part of the work, of course, that you're doing is not directly related to, but in conjunction with Dr. Peter Unruh. Peter, thank you for joining us tonight.
Well, it's great to be here.
You're doing something that I think is vitally important in helping to speed up the rate at which we get accurate information as to whether or not somebody has been infected by COVID-19.
Yeah, so one of the key, if we extend this analogy that was brought up about forest fires, we have a forest fire that we've kind of suppressed, but it would be very good to know where the embers are. Uh-huh. And testing is something that allows us to uncover that information. And if testing can be reliable and cheap, it could really change the way that we live our lives, because we'd be far more certain whether we were a risk to others, whether schools should be shut down or the like. So our group is very interested in rapid testing using technology that is, we think, reliable and quick. So we hope to get that out onto the market as rapidly as possible.
Well, the testing, as I understand it right now, it's kind of a cumbersome process. Like the sample has to go to a central lab.
Well, it's even worse than that.
It's worse.
You have a swab stuck up your nose to the back of your throat. This is kind of painful. So you're not going to do it to you're not at home going to stick a swab to the back of your child's.
So you're already expressing symptoms of,
So the test is quite invasive, right? Mm-hmm. So if you're sick and you go to the hospital, the emergency ward, that's fine. I suppose you're going to put up with that, but you're not going to do that kind of testing at home on your children. And so it's
right.
Getting a test that's reliable, cheap, works with a family could implement it. These are difficult questions that we're trying to address as rapidly as possible.
And so the current process is you have to get that swab. That swab then has to be quarantined in essence and arrive at the lab.
Well, it's sent to a centralized facility.
Yeah.
And if you're lucky, a day later, you find the result.
That does not give an opportunity to make rapid decisions. It isn't providing Carolyn with the kind of information that gives her most accurate, up-to-date information. So how are you then addressing this situation so that you can, your devices, the RNA Mango?
Yeah, so we have a technology that detects RNA very sensitively. Yeah. And just quite fortuitously, actually, we were working on RNA detection inside living cells. We're interested in how RNA moves around inside living cells. And when this virus came out, our technology seemed almost perfectly suitable for making a rapid test. And so we can synthesize an RNA molecule that binds to a fluorophore that starts to glow if the RNA molecule is actually inside the tube. So provided you can get the sample into the tube rapidly, you have a rapid test that we believe could be made reliable enough, perhaps for a family to use.
So is the testing that is out right now reliable enough, even though it is this cumbersome process?
Oh, it's quite reliable, yeah. So there's since the last SARS outbreak, that's basically the protocols that we're using. It's quite established technology, sort of 20, 25 years old, based on reverse transcription PCR. It is reliable. It's just, it takes time to run the assay, and it does take time to bring the samples to a centralized facility. It requires expensive machines actually to run the test. So, a machine is 50 to 100 grand that you're running the test on. A family is not going to spend 50 to 100 grand to do a test. So the technology that we're using is all isothermal. So it works at one fixed temperature, which means that in principle you can get the sample going, and a device $50 to $100 can can run the test, right? That's something that in principle you can buy at a grocery store or a London Drugs.
You anticipated my question. Is this something that's going to be available to the average person so that they'll be able to make quick decisions about whether they have been infected?
We're hoping that ultimately we can get there. Is just a lot of technological development compressed into a very short period of time. So our first aim is to put this technology into centers where they have the ability to do reporting, like hospitals, potentially airports, for example. Like you'd go through a security station, maybe get a sample collected as you're going through security. Maybe when you're waiting to get on the plane, somebody taps you on the shoulder and says, like, perhaps you shouldn't get on the shouldn't get on the plane.
Well, and in my mind, I think, don't we already have that ability? But we don't, do we?
We don't practically at the moment.
Yeah. And so what's it going to take to get from the stage that you're at right now to actually being able to have that ability?
Well,
Money, I know money is going to be one of them.
A lot of dedication. I mean, it's a matter of investment, really, by governments. And the team that we've put together has been funded so far by CHR. They put together a rapid response fund to do this, and there's 5 teams working with us. One of them is right next to me, who's working with me.
Dr. Rob Britton, yes,
the chemist. But we have clinicians. We have people in engineering who are engineering the actual device that we're building to do the test, where the biochemistry that we have will be inserted inside.
Yeah.
So there's a lot of moving parts in this project.
Yeah. I just want to let you know that there have been some questions coming in. Please, if you have a question, feel free to send it in. I get it here, and then I can pass it along. So how do we then get to a stage where, we have to have a high level of certainty when it comes to this kind of testing? Because, if you start getting false results, then it's going to create, it's not going to create a sense of safety. It's going to create an enhanced sense of uncertainty.
We've already had quite a few tests that have been reported in the public media that have just not been very good. So reliability of the test is really quite fundamental. And particularly, you don't want to have a test that says you don't have the virus when in fact you do.
Well, yeah, because not only is your own well-being at risk, so is that of others, because it's so easily transmittable. Yeah.
So making a test that's cheap and reliable is the difficult part, right? So it's we think we can do it for perhaps $50 to $100 for a test, for like a test that a family could use.
There's people who are watching this right now saying, okay, you talked about money, but you didn't answer the time question. How long before I can have one of those?
well, we have to get approval from the various government agencies. I think that's at least a month or 2 at the shortest.
Yeah.
To get that kind of approval. But past that point, if we can find a company that can actually package things, maybe another month or 2 after that. I mean, these are all questions that are very pressing.
So if we are able to meet our goal here of raising $200,000 as a result of this campaign, and we hire these 2 postdoctoral students, how is that going to help you in being able to do the work that you're doing?
Yeah, I think we have a good team assembled, and a key part of this project is to make an internal control that is as reliable as the external control that we're using right now. And that particular project would need a person to actually implement that over the next couple of months. So what we want to have, instead of having 2 tubes doing a test, we want to have 1 tube. And in that 1 tube, 2 colors emerge. One is saying that, yes, this test is actually a valid test. And the other one is saying, well, unfortunately, you actually have COVID-19. But if both are blank, that just means the test didn't work. And if we can get to that point in a month or 2, that would be beautiful.
So it will help you significantly.
Provided that we can do it immediately for this particular COVID-19 response. Otherwise, we will have technology that we'll be developing for future outbreaks. But
right. So
right now is the time that we need to.
Right. Well, you pointed out that this was work that you had started before the outbreak of COVID-19, and you were working with Dr. Britton at the time. So there is some good fortune as timing that you're already quite a significant way down this path.
Yeah, we basically pivoted onto sort of imaging of COVID-19, if you want to think of it that way, versus imaging of RNA inside of cells. And Rob's group has been really quite instrumental for the chemistry of all of these projects.
And that chemistry is vitally important, isn't it? Rob, thanks for joining us tonight.
Yeah, it's great to be here.
Yeah, you are working in that small molecule space, and it's fundamentally important, especially as we look at the ways in which we're going to respond to COVID-19. Everybody keeps talking about, I want a vaccine, I want a vaccine, I want a vaccine. But we also know that there are a tremendous number of challenges around creating a vaccine. With this small molecule research that you're doing, it really moves us towards therapeutics, doesn't it? And why is this a good and reasonable strategy for us to be embracing?
Yeah, it's a really good question. I think you can see what's happened in the current pandemic, where the first thing that people turned to were small molecule therapeutics. And people began back in January rapidly screening antiviral drugs to see if any of them had any efficacy against COVID-19. And they found early on that a molecule called remdesivir did. And so this was pursued and about a month ago, or just maybe a bit more, received clearance to be used on large scale.
And it looks like it is effective.
Yeah, it certainly helps people. It reduces time in hospital. It's not the silver bullet everybody wants. No. It's not like taking an antibiotic for an infection that's well understood. But this molecule wasn't made to treat COVID-19. It was made for other purposes, and essentially got repurposed rapidly in this pandemic. Yeah,
originally for Ebola, wasn't it?
That's correct, yeah.
Yeah, and it had some efficacy, but wasn't considered to be like a knock it out of the park success. But it clearly seems to have an application here.
Yeah, absolutely. And you can see that one of the major challenges now, though, is making this drug. So the company that discovered and developed this drug wasn't ready for COVID. They thought they might, at some point treat thousands of people, not millions of people. And so it was
hundreds of millions.
Or hundreds of millions of people. Yeah. And so it's been a monumental effort on their part to try and scale up the production to the point where this can be readily available, like any drug you'd get from a pharmacy.
So it's my understanding that within this small molecule research that you're doing, what you're doing is you're creating what are the nucleoside analogs? Is that correct? And that in doing that, you're helping to reduce the ability of the virus to replicate itself.
Yeah. So essentially, how it works is, most of the antiviral drugs that exist are what we call nucleoside analogs. So these are molecules that look like naturally occurring nucleosides, but the virus is tricked into incorporating them into their RNA. And when this happens, there's defects then in the virus's RNA that make them incapable of surviving. And so it's you can essentially trick the virus's own machinery to put these kind of dud nucleosides in their RNA, and as a result, they are destroyed.
So in essence, when they're replicating, they become mules.
Yeah.
They're unable to then replicate after that. And so then it becomes a self-defeating process of replication.
Yes, well, essentially, yeah. So this is one way that nucleoside analogs can work.
So it's like, how important is it that we really do focus our attention on this? Because, we do hear so much about vaccines, as I mentioned earlier, but the virus is going to keep changing. If we keep coming up with these small molecule related treatments or therapies, is that not a better way for us to be able to kind of manage our risk as we move forward?
Yeah, it's one way. I think it's a good question. I think in the long term, obviously everyone's waiting for a vaccine, and this we hope will take care of things. But viruses are constantly changing, and as they change, we need therapeutics to address the issue until there's a vaccine. And we've already seen what lag times for vaccines can be. And in the current case, this is a real heroic effort that's being undertaken to even have a vaccine ready, maybe within a year or slightly more than a year. And so there's always going to be a need for these small molecules. And the challenge really is making these things. And so what we started working on long before this, about 4 years ago, we recognized that the kinds of molecules that are used as antivirals are really tough to make. People spend years trying to make these things, and they're really limited by the existing technologies for making these types of antiviral drugs. And so we focused for 4 or 5 years just on developing new chemical reactions that lets us make these things easier, faster, cheaper, and lets us change their structures so that we can target different viruses And in the midst of all of this, we came into the current crisis.
But by being able to move far more, affordably in the development, and it's a synthetic that you have developed, isn't it? And as I understand.
Yeah. So these essentially, what we're doing is we've discovered ways to make molecules that kind of look and behave like nucleosides, these naturally occurring building blocks that exist in nature, but have slight changes to them. And the kind of changes that we make to these molecules were traditionally very difficult. So it might take months or years to make one of these molecules. And what we've done is tried to rapidly accelerate this, not as much for cost, because the cost of drug discovery is always a big deal.
Yeah.
It's more about time and being able to make more of them so that you can test more compounds.
So that is the key, because then it leads to the development of the therapeutics.
Absolutely.
Doesn't it? And so when we take a look at the therapeutic approach versus vaccine, I can't help but think back to 30 some odd years ago when HIV/AIDS was first presented, and we became aware of it. It was Dr. Fauci who was claiming that there was going to be a vaccine within a number of years. We don't have a vaccine, but we have a therapeutic approach that literally now when you get diagnosed with HIV, the likelihood of it advancing to AIDS is minimal. The mortality rate has come so far down because of this attention on therapeutics.
Yeah, and that's a great example, because the therapeutics that have been used in that case are all these nucleoside analogs, right? These molecules that mimic nucleosides and trick the virus into destroying itself.
Yeah, and so much of that research, like the work that you're doing, was done here in Vancouver.
Yes, I'm sure it is, and all over the world, but a lot of this was done in Vancouver, yes.
Yeah, so given the fact that we're out here to raise money, remember the donate button. Please support this research. But we hit our target. We hire these 2 postdoctoral students. How's that going to help you with the work that you're going to do?
Yeah, so the kind of thing. I mean, I say that we've made it easier to make these types of molecules, right? And now what we want to do is exploit this technology and make lots of these types of molecules so that we can screen against viruses like COVID-19.
Right.
And try and find better drugs for treating, or drugs that are specifically developed for treating this virus.
Yeah, and human resources are a vitally important
essential
component in research, aren't they?
Yeah.
The intelligence of people working together, individually and collectively, will make a big difference.
Yeah, so in our case, this is absolutely something that's driven by manpower.
Yeah.
We need lots of people making these molecules. It's not like these are made by a robot or made in some automated fashion. This is all done by hand, by people. And the more people working on this problem, the quicker we'll get to a solution.
Yeah. So we're at that point now where we're going to start to move into the conversation with all of you to have an exchange of ideas as we move along here. Now, when it comes to you look at the interplay between the 3 of you, how important, Carolyn, is it that you get the kind of information that the rapid testing can provide to you as you move forward and develop the next model?
Well, that was going to be my question for you: is can I use your data? I imagine families all over the country or all over the world are running an at-home test kit, and could you link it up to a quick 1 or 2 minute survey? How much have you been out of the house last week, or how many people have you been in contact with in the past 7 days or in the past 10 days? And could we use the data?
Well, I don't see any reason why not. I mean, the design of the device that we're thinking about at the moment would be connected to a cell phone. So when you do the test, you would upload to some centralized facility that would then, I guess, also report related information, I guess, if it was asked in the app that was being run on the test.
Right. And I think one of the incredibly exciting things about that would be to get information about exposures that did not lead to infection, because we often record information about people who test positive. And in epidemiology, we tend to, sadly, not always, we tend to disregard those negatives. And learning that okay, you went to a nightclub, you didn't get infected.
miracle.
Wow, that's great. Yeah. So maybe not, and of course that depends on whether the nightclub had any cases in it. But you would also potentially know that from your testing data. You might know local prevalence, and I think it would just be very, very informative for transmission modeling to use those data.
Well, if we or others can make things really cheap and robust, that is possible.
And people could choose
it
on
will
their
require
phone.
a global effort of people trying to produce tests that are really cheap to make that
Right.
possible. But it's that kind of thing could be imagined, not just for COVID-19, but for any kind of viral outbreak. I mean, you could track the flu this way, I suppose.
Right.
as well.
Okay, here's a question for all three of you. At the moment, do you think that we're safe to start to embrace our families again, move back out into the communities?
Or
Yeah,
immediate
from each of
families,
you.
immediate families, or
Well, sure, and even our extended families. We hear about a family goes, oh, good, we can get together, and the next thing you know, they're reporting cases of COVID-19. From your perspective, where are you at on that?
I don't think I'm particularly comfortable right now.
Yeah, so you're still being very cautious.
Yeah.
Yeah,
Yeah, I'm still being cautious as well.
yeah. But and is it restricting your movement, or are you just saying, I'm going to make sure that I'm respecting distances, I'm paying more attention to my
No,
own?
it's both restricting movement and respecting distances.
Yeah.
I think both of these things are still important.
Yeah, yeah. And Carolyn, how about you? You're at the epicenter of all this information. How's it
Right.
influencing you, and how do you think that if you were asked, we ought to be thinking about our desire to get out and socialize?
Right. From a COVID-19 point of view, I do not think we are in a good position to reopen. From a broader point of view, it's a different question.
Mm-hmm.
I think you've also mentioned safety and being safe and feeling safe. We are never perfectly safe. The actions we're taking are having impact on mental health, on physical health. When you drive a car, you're not perfectly safe. Doesn't mean you stay home all the time. So
Yeah.
should we be asking the question, are we completely, perfectly safe? You're never perfectly safe.
Never.
You eat,
Yes.
you walk, you could trip and fall and break your neck. We could
Right.
have, and we imagine that we are in control of those things. And this
Yeah.
is a brand new special way to die. So that's scary.
Yeah.
So from a COVID-19 point of view, no, I don't think we're particularly safe to reopen and reestablish contact. I think we
Right.
should maintain our distance. It's the thing that we know works. The only thing that has really consistently worked
Yeah.
is staying away from each other. And I think as much as possible,
Well, and we saw
I
the
would
results.
cast
didn't we?
my vote for keep doing that
Yeah.
as much as we can, but we can't do it forever.
Right. Well, now just before we get to the question and answer session from Peter, you've got something. I can see that you're chomping at the bit. You got something else that you want to add here?
No, I just think, eventually this pandemic will be in the rearview mirror, and we'll all get to regroup and think what went right and what went wrong.
Right.
But I think, BC is doing a good job right now. We should keep doing a good job.
Yeah.
And
Yeah.
Okay, so I want to get to some of the questions from people or viewers, but just before we do that, I'm pleased to let you know that we received a message from Dr. John Clegg, who is joining us online, watching us this evening, and he's supporting the Path Forward campaign and the work of all three of you and the entire campaign, and he wants others to do the same. So as an incentive, he has committed to matching dollar for dollar all donations to the Path Forward campaign up to $10,000. And so, this is, let's give a big shout out to him. What an amazing commitment, Dr. Clegg. Thank you so much for that pledge, doubling all of our donations. So here's where we're going to go back to the question and answer session, and we're going to be taking questions from people who are watching. Here's the first question. How much are you and the province anticipating our case count will go up as we enter into the next phase? That some people are calling phase 3, but maybe you're not even calling it phase 3. I leave it open to you. Who wants to go first?
well, there's one expert over there that probably knows the answer to that question.
Carolyn.
Yeah, so I think we really can't, we can forecast this.
Yeah.
And what we do is we imagine that people change their behavior in different ways, and we run our forecasts, and the answers are kind of all over the map. If we slow down, we can crush the curve some more.
Yeah.
If we open up, we can rise again. I wish I had the picture in my head. I've got a picture from Dr. Henry's slides that is the answer to what we forecast for that
Yeah.
question. I would say, right now we would forecast a gentle rise through July as we reopen. So
So you expect to see a gentle rise through July, and there's many people who go, yeah, but when we get into the fall, it's going to be even more pronounced because, like anything, we get into those colder, wet months, and we're more vulnerable.
With more indoor contact, I think that's more vulnerable. We don't know what people will do, what policy will do. I think phase 3, reopening TV production, I wouldn't imagine that's going to hurt anything. It's the travel. I think we focused on reopening tourism, and we risk introducing cases to places where they haven't had them or haven't had very many of them. And I think that's where the risk really is.
Thoughts? No,
I think we've heard from the expert.
We've heard from the expert. Yeah. So we've heard that that there have been a considerable number of cases in Alberta that kind of mirror what we're here, but there's differences, and so what do we have to take into consideration from that perspective? That's a question that's come in. Like, do we need to then continue to think about, no, we got to stay in our province? Do we need to shut down that kind of travel?
So I think that's something we've modeled, looking at kind of travel bubbles and how good an idea is that. And I think it can be very risky when travelers are likely to land in, activities or congregate settings or workplaces where they have a lot of contact. And where they're not plugged into the public health system. Mm-hmm. So if I go to a different province, I'm not in their healthcare system. I've got my BC. Do I know where to get tested? Will I get tested? Will I go off and be in social activities or tourism activities? Will I have more contact than I would have if I stayed at home with my laptop on my screen? Yeah, I probably will. And so I think that is a risk of interprovincial travel. On the other hand, we have low case numbers, and maybe there's a good rationale for taking some of those risks. We do take risks in life. We don't do everything we can to avoid all risk. It's part of life.
Right. So Peter, Rob, one of the questions that we keep hearing a fair bit, and this might fall more into your area of study, is I get the flu, I develop some sort of antibody, and then I can I'm probably gonna be not get that flu again. What do we know about COVID-19 as far as the development of antibodies if you have been infected and you fought your way through it and now you're back to wellness?
Well, it seems contentious at the moment, but I think people do get antibodies. I think you probably don't get it a second time, but I just say probably because I don't think we know that absolutely at the present time.
Well, I get the cold many different times because there's different strains of it.
Well, the coronaviruses are a nasty set of viruses, and 1/3 of colds are coronaviruses. And what we have right now is a coronavirus. We don't have much luck with coronaviruses and vaccines, or how we develop immunity to them quickly.
Well, then that comes back to therapeutics, doesn't it? Isn't that the way that we deal with colds?
It's an interesting question as well because we talked about the first line of defense being small molecule therapeutics,
right,
and the last line being vaccines. But in the middle of all that is antibodies, and there's been an enormous global push to identify antibodies that can be used as therapeutics. And these are things that we hope we'll see at some point this fall or late fall.
So we're moving quickly.
Yeah, it's been incredible how quickly everyone is mobilized.
Okay, and is that because we're forced to a rapid response? In the development of most science, you talk about the devices that you are, the RNA Mango device that you are developing. Under normal circumstances, the approval process would probably take significantly longer.
Way
than
longer,
what you're going through right now. And so is there in some ways a benefit to say, we're going to push the science through and we're going to push it through quickly?
Well, to the extent that when your house is on fire, you decide to put it out, that's a good idea. Yes, that's a really good plan. Right?
Right.
It's better to have a bit more planning that way. And governments around the world, I think, have been caught a little short on planning in this respect because some governments have actually anticipated things and other governments have completely not. And there's the entire spectrum in between.
Right.
But the fact is, people's houses are on fire. If the analogy is the infection in one's country, and putting that out is a priority, right? So it's unfortunate that that's sort of how rapid we have to do things because of a perhaps a lack of prior investment and foresight on how fire prevention could have been managed for
Right.
viral outbreaks.
But the same would be true with small molecule research and the role that it will play in developing other therapeutic approaches.
Yeah, and I would say one thing that's been really positive, certainly in Canada, is the government's response to science funding in this case. I think we've benefited already from some of these rapid response grants, and there's many more of these that are helping us understand this virus better and come up with ways to treat the virus. And so I'd say, one thing I've been really pleased with in Canada is the response that's been made by the government and the funding agencies in the country to help as well.
So the question comes back from people who are watching: are we opening too quickly? Each of you, what's your response? I mean, you talked about what your own personal risk level is, but when you take a look at the landscape as a whole, do you think we're opening too quickly?
Well, I think the question that nobody's, including governments, I've heard. I mean, when are we going to open borders between countries? I mean, I don't know the answer to that question. I mean, maybe you have ideas about it, but I mean, it did originally travel around the world very effectively, and then we shut down travel, and at some point we're going to open up air travel again, and then I suppose it can travel again pretty rapidly
Well, is it still traveling?
Yeah, it is. And I think this is an interesting pandemic, and it has given rise to an unprecedented level of border closure. The WHO did not originally really recommend border closures, and that's based on pandemic flus, where really border closures kind of delay the introductions, but they don't prevent them, because even if you close borders, you're not completely sealed, and we have quite a globalized world. But we're in this unique place where we've stopped this a little bit or slowed it in its tracks. We don't have immunity. We have widely different prevalence. We have a country to our south that is not doing great right now with COVID-19 control. If we reopen these borders and we're not able to contact trace and really keep track of people who come in, and we can't effectively quarantine people for 14 days and reopen our border, it's just impractical. It's going to be a problem. That's going to be the embers. Those embers will arrive in our dry forest, and they will cause
and if you can detect part of the problem is we don't know how little virus can be in a person, and that person be actively infectious, right? So the sensitivity of a test is really important. So if you can detect that somebody has a very low viral load and maybe getting sick or might be getting better, or whichever way they're going, that's, I think, really important, because they may feel perfectly fine, right? They're just crossing a border, or they're going into the drugstore to buy something. Your
technology would be completely transformative.
Yeah, so
if we can do this.
I mean, it's detecting down to the level of detecting individual molecules. That's the problem with it. It's a hard thing to do, because I mean, basically you can count them if they're in the tube, but that could mean that somebody is rapidly, maybe tomorrow they're going to have a fever, right? That you could detect.
With your technology, we could in principle test 5% of the population every day.
Yeah.
And
so it's a lot of tests.
That's a lot of tests. Maybe 5% per week. But that's the level that those are the levels that have been talked about for really using testing as the primary mitigation tool. And that's far beyond what we can do by shipping samples to a lab to do PCR.
Yeah, so it has to be super cheap.
So look at how exciting this conversation is, because it's dynamic. There's so many areas of discipline. This is a great discussion, and I wish that we could keep going on, but we actually have to wrap up. It's hard to believe that our time is pretty much up. So thank you, all of you. Now, before we wrap up, we've got a video that we want to share with you at this moment that highlights the big vision of the Faculty of Science at SFU.
Dozens of wildfires continue to rage across the Okanagan Valley.
There's been a fuel spill in the waters off Vancouver's coast.
Growing concern about thousands of sea creatures washing up dead on their shores.
Extensive damage there after a powerful earthquake.
Major health alert tonight, the Zika virus being spread by mosquitoes.
Serious damage to our local agriculture.
4 countries are on the brink of famine. 20 million people, families and children.
been made soon, there will be irreversible damage to the planet.
That is the big vision at Simon Fraser Faculty of Science. Thank you for joining us tonight. Good night. SFU science researchers are changing the game. And as we heard tonight in conversation with Dr. Carolyn Colane, Dr. Peter Unruh, and Dr. Rob Britton, they are doing extraordinary work and are part of a global effort to make sure that we are safe. All of you can join in the fight against COVID-19 by investing in science to show that there is a safe path for our communities to move forward, and by supporting SFU Science, the Path Forward campaign. Your support will help to ensure the acceleration of the works of Dr. Colane, Britton, and Unruh, helping to ensure all of us and our loved ones continue to stay safe. Please use the link below on the screen to make a donation and connect with the Faculty of Science at SFU for more on this conversation and further conversations. Thank you to our game changers, Dr. Colane, Unruh, and Britton, and thank you all at home for joining SFU Science for this vital town hall. Please stay safe.